dealing with, and would love any insight as to how to deal with it. So this is a 51-year-old female who had a past history of lymphoma that was treated with chemotherapy and radiation in 2008, who now presents with worsening shortness of breath and edema. She really can only walk about 50 feet before she has to stop. She has no chest pain or syncope. She has been admitted 3 times in the past 4 months for volume overload. Her past medical history is quite complex and includes hypertrophic cardiomyopathy for about 15 years. At some point in the past, about 2007, she had recurrent atrial fibrillation. They attempted, they didn't actually attempt an AFib ablation, but they ended up with an AV nodal ablation and a permanent pacemaker, VVI pacemaker at that point. She has had normal coronaries on 2 different times, 2 different caths. And then, as mentioned, she developed Hodgkin's lymphoma in 2008, was treated with 6 cycles of CHOP, and had mediastinal radiation for bulky disease. About 6 months after she finished her chemo, she then developed LV dysfunction and heart failure with an EF less than 20. And then over the next 6 months to a year, she had several episodes of ventricular tachycardia requiring admission, and this was in 2010. And ultimately, she got an ICD placement and was placed on amiodarone for about 1.5 years. So now, at the current day, her blood pressure on average is about 96 or 100/60, heart rate 76, and paced. She's afebrile. Her exam is notable for significant JVD, several centimeters above normal. She does have apical crackles on her lung exam. Her cardiac exam, she has a systolic murmur that's pretty loud at the right upper sternal border. She has no S3 and her PMI is enlarged. Her extremities show edema all the way up to her thighs, and she does have good pulses. Her basic labs are below, with a sodium of 133, BUN and creatinine. Her potassium is 4.6. Her BUN and creatinine were 46 and 1.5. Hemoglobin is okay. BNP is significantly elevated. Her troponin is negative. So here's her chest X-ray. I don't know if anybody wants to take this one on, especially Joe. I've lost my video. Oh, okay. I don't know, Eric, if you want to make a comment about this X-ray.
Ask Dr. Morales, our imaging fellow.
Well, you can see the heart is obviously grossly enlarged. You see an ICD wires with dual chamber pacemaker leads in place. There's some significant congestion in both lungs, with no significant effusion noted on the right, and blurring obviously on the left. The upper mediastinum is obviously widened as well.
Okay. And so do you think this is all pulmonary edema, or what do you think?
It looks like pulmonary congestion, yeah, pulmonary edema. There looks to be some cephalization as well.
Okay. So she, she did have mediastinal radiation, and after her radiation for about 6 months to 9 months, she was on prednisone for and inhalers, etc., for pulmonary related toxicity from her radiation. Here's her EKG. I don't know if anybody wants to tackle that one.
Let's see. I see ventricular pace rhythm. Looks like with the left bundle morphology, so right ventricular pace. as far as underlying atrial rhythm. I don't see. It looks like a three-way. Go ahead.
Yeah, it's hard to see, but she's been in AFib for a while, so.
Yeah.
So her current medicines are listed here. A little bit of Zocor, Coreg at a very tiny dose, and then a bunch of diuretics, and you see them listed. Pretty high dose torsemide, spironolactone, and then she has to take metolazone intermittently. So just from what we know so far, does anybody have any ideas of what other medicines we should use or should take away, or do we have any thoughts on that? The other would be, what kind of other evaluation do you think is necessary to be able to figure out what to do?
I wonder if some component of her cardiomyopathy could be the fact that she's been chronically paced, RV paced, and maybe synchronizing her or placing a CRT device, biventricular pacemaker, may help improve some of her symptoms.
Yeah, that's actually a really good point, and I think at the time that her LV dysfunction was so severe, and she had, she was having VT, I believe they attempted an LV lead, but I'm not sure how hard they tried, but they ended up just putting an ICD in. So that's certainly an important point. Would a biventricular pacer be useful in this situation? Again, the patient's in chronic AFib, so there's not quite as much data that that's helpful, but nonetheless, that's an important point.
Dan?
Yeah.
Am I still muted?
Not anymore.
So I always hate to fall in the trap. I would definitely want to make sure that she did, with her previous radiation, that she doesn't now have coronary disease that's contributing to the whole business, and that I would do something to figure that out, and maybe cath her, just to be sure, because there are not that many giant options for her. And right. You have an echo. She doesn't have a big pericardial effusion or something.
No. So okay, let's take a look at that. Here's her echo. Dr. Morales, you want to comment on that one?
Sure. I mean, it's kind of in slow motion, but obviously her left atrium is ginormous, is very enlarged. Left ventricle looks very poor, but it's sluggishly moving over here. You can see a right ventricular giant lead, ICD lead, extending into the right ventricular apex. I don't see any intraatrial septal bowing right now. But
what do you think about the septum?
The septum looks enlarged, looks thickened, obviously, and it's kind of hard to see the lateral wall, the antilateral wall in this view.
Yeah.
Hey, Dan?
Yeah.
So, her ventricle is relatively small and thick. So the other question is, could you conceivably try to do an AF ablation and get her back into sinus rhythm?
She had an AV nodal ablation many years ago. So she's been in chronic AFib for more than 5 years. So I think that although that's a possibility, I think it's not very likely to be successful. So I don't know if you have it. This is another view of it.
He doesn't have that many options.
Yeah, well, so what do you guys think about this echo image?
This is interesting because of the asymmetrical septal hypertrophy, which patients with HOCM frequently develop congestive cardiomyopathies as the end stage, and they dilate and stretches, and you really don't see the ASH like you used to with in those. And this one still has retained that and has not dilated that, and the ventricle doesn't look all that dilated. The lateral wall looks like it, you know, what I see of it has some motion, and the septum seems to be thickening, but not moving a lot. This ventricle actually shows some promise, and I'm more enthusiastic after seeing this for BiV pacing to see what we can do in synchronizing it, because that lateral wall is going to be coming in late. And so I'm more enthusiastic about the BiV seeing this. I'm more enthusiastic about this ventricle, too, seeing what's been preserved.
Yeah, what do you think about the mitral valve, since we're talking about mitral valves?
Yeah, there might be some mitral valve prolapse. I see some bowing back there posteriorly in that anterior leaflet, but and we don't see the amount of mitral regurgitation, which would be interesting. But with the BiV, as I said, we've seen frequent mitral valve regurgitation improvement dramatically with BiV. So I would go with the BiV before I do anything, and get somebody who's more committed to putting a BiV in. Sometimes the angioplasty doctors are better because they know how to use the guiding catheters and the wires, and they can get in there and get that lead into the coronary sinus.
Yeah, well, the other thing is that you can see part of that chordae that's kind of in the LV outflow tract, so that's a little bit of a problem. We didn't really demonstrate any sort of clear obstructive behavior from that valve, but nonetheless, that adds to the mix.
Yeah, that's very interesting. That's called systolic anterior motion of the cord. And so you can see the cord being sucked in by that sort of Venturi-Bernoulli effect.
Well, and then just that, so here's her TR velocity on that echo, and you can see that her she has some degree of pulmonary hypertension with the estimated pressures probably in the mid-50s. You can see the velocity is a little bit, it's 3.1 or 311 centimeters per second. So, and then if you add the right atrial pressure, hers are significantly elevated, as you might imagine. So her PA pressures were felt to be in the mid-50s.
But her RV looks pretty good in terms of the size and the wall motion. So I'm a little more optimistic about the BiV in this patient.
Okay, well, that's good. So here we did do a cath, Joe, as you suggested, and the coronaries were still normal, which was good. That was one less thing that we had to deal with. But this is her. These are her pressures. Here are her pressures from the right heart cath, and the significant things are that the right atrial pressure is quite high. You see it's in the 20s. RV pressure 59/10. The PA pressure was 56/21. Mixed venous sat was 61%. And then her LV pressure was 93 over, and here they say 14, but you know, by my review of the end diastolic pressure, it was a little closer to 20. It was about 18 actually. But so what do you think about that? Anybody?
Well, I would think that a lot of it is backward failure. We don't see a gradient, a subpulmonic gradient, so that's good because we frequently have that septum bowing across and get sort of hokum on the right side as well as the left side, so we don't see that. I don't see an intraventricular pullback. I guess there is.
Yeah, there was one done, and there was no LV outflow tract gradient. So then I wanted to show you the pressures just the pressures themselves so that you get an idea. And here's the in the top left is the right atrial pressure with a mean at end expiration close to 20. In the bottom left, that's the wedge pressure, and at end expiration, it's also close to 20. Her RV pressure is on the top right, and you can't see the scale, but the pressure is into the mid-60s. You see the top of the pressure scale. That black line is 50, so it's in the 60s. And the RV end diastolic pressure is also in the mid or low 20s, so you definitely get a sense that there's a equalization of, potentially equalization of pressures. And then on the bottom right, that's the LV pressure, and you see the end diastolic pressure there. That mid line, the black line, is 100, so the end diastolic pressure is about 20 at end expiration. So, this is a tough case. We got pretty significant pulmonary hypertension with the LVEDP in the 18 range. She's pretty well diuresed.
Did you give her any nitric acid to see if the nitric oxide?
We didn't actually. I wish they had. That's a good point. But just to add a little bit more to the mix, and this is definitely something that Joe would be familiar with. But so here's her chest CT. Dr. Morales, do you have any comment on this?
Yeah, definitely. Go ahead. I'm sorry.
It's up near the apex.
Okay. So, yeah, I mean, there definitely looks to be some airspace disease of some sort. Looks almost honeycombish a little bit. So some disease involving the lungs as well, which kind of makes sense because a lot of her pressures, some of it looked like it was left-sided, but also some of it looked like her pulmonary vascular resistance was also elevated, implying there may be some underlying lung disease, possibly radiation. But I think she received radiation in 2006 or 7, which would be a little too early. What I would think, usually 15, 20 years, I believe, is when you start seeing the onset of some of those changes. But
yeah, well, I think that it's one of those things that she had pretty significant pulmonary issues at the time of radiation, so I think that they probably exceeded her pulmonary's capacity to deal with the radiation early on, and so I think that what we're seeing here is probably something that has occurred much earlier than the 15 or 20 years that you might expect.
I guess we're still worried a little bit about constrictive pericarditis in this patient with a radiation exposure, and rather than a restrictive process of the heart.
Yeah, so that's true. This is another image of the CT, more focusing on the apical portion, but you see that sort of dense infiltrate or airspace disease as was previously mentioned. So I think that she's got some significant lung damage, and perhaps that explains some degree of that pulmonary hypertension.
She ever been screened for tuberculosis with the PPD, Marty?
So yeah, I would hate to add another problem to the list, but I don't know. I'm not sure if she has. That's a good point. So then I would want to point out another recent article. This is from Greg Armstrong and his group at St. Jude's Children's Hospital in Memphis. And, it was really looking at long-term survivors and identifying tricuspid regurgitation that was pretty significantly elevated. And what I have on this slide is basically the a portion of the abstract, and you see the reference there. So this is just published in February, and they find that long-term survivors who got mediastinal or thoracic radiation have a much higher incidence of non-invasive measurements of pulmonary hypertension. And then the question is what do we do about that? So I don't know the answer to that one. I don't know if Joe could make a comment on that.
Well, the first thing is these are kids, so I'm not sure it's directly transferable to adults who get treated for Hodgkin's in their 30s or 40s.
No, these are adult survivors.
Yeah, but I know, but they were that I think that the effects on the lung may be different when you're in a kid than in doing an adult. And remember that because they're adult survivors, a lot of this cohort was treated in the days before they did all the blocking stuff that we currently do, and doing transformal radiation therapy rather than ortho voltage all over the place. So do I think it exists? Yeah, sure, yeah, but for her this was not the entire picture.
No, I think she's got a bunch of things, that's for sure. So, all right. So what do we do now? This is what I really want to know.
And I had a session-breaking other call when you were doing the hemodynamics. So, was there any thought that this could be sort of low-level constriction that's blocked a little bit, or she's got hypertrophic disease, and so I'm usually not interested in a million things, but a dedicated cardiac MRI to look at the pericardium and see if this is sort of early constriction, and if that's the reason that she's having so much trouble.
Well, she has a device, and so we couldn't do an MRI, but she did have a chest CT, and the chest CT didn't show any real significant pericardial thickening. So okay. I don't know. An MRI would be nice, but so I mean these are the hemodynamics, and she does have some evidence of elevation and equalization of her diastolic pressures, but they're not right on each other, and there does seem to be a predominance of RV pressure, PA pressure elevation outside of the degree of LVEDP elevation. So there was about a 12 to 14 millimeter gradient between PA diastolic and the LVEDP. So anyway, she's a tough situation, and I just wanted to for a couple of minutes just talk about pulmonary arterial hypertension, just because I think it is one of our most difficult things to struggle with. And actually, Adam was on the call at one point. I don't know if he's still there. But Adam would be somebody that knows a fair amount about all this, and if he can figure out how to make a comment, I would love to hear it. But this is sort of the current classification of pulmonary hypertension, and the group 1 is sort of the classic idiopathic or familial pulmonary hypertension. And then the second group is the one that we most commonly deal with, is that they have left-sided heart disease that results in pulmonary hypertension. And that's kind of what you had on their first case. And then the other groups are the ones where you're not sure where to put this. So in this patient, you could make an argument that she fits in group 2, or more so that she may be in group 5, since I think she probably does have some degree of fibrosis. But the problem is that whichever place you put her in, the question is what therapy can you go, or what can you do to try to improve this situation? And we've already talked about different procedural type things, whether it be a IV pacer or pericardial stripping or something like that. Those are all possible options. What about medication? So I did want to just come on.
So, you could take her back. You could conceivably, just in what's the least that you could do and the least dangerous for her. You could probably take her back to the cath lab for hemodynamics and see how responsive her PA pressures are to medication, and then ultimately see if that makes a difference.
Yeah, I think that.
Hello, I'm on. Happy to talk to you because I was muted all the time. So it's Adam calling from
Fantastic.
Thank
you.
Okay. So now I'm listening, but I can also comment when you want me.
So, do you have any thoughts on this patient in terms of pulmonary hypertension, and is there where would you classify this patient and so on? I don't know.
I think you are absolutely right that there are at least 3 groups that she can fit in, and this would be left heart disease because obviously her ejection fraction is quite low. I think there is probably some degree of diastolic dysfunction also because she had this thickening of interventricular septum, and then she was radiated, so probably the muscle is not perfect. Then you have, of course, the problem of damage of her pulmonary vessels, and this will contribute to pulmonary hypertension and to elevated pulmonary vascular resistance. And these are probably the two most important issues. I don't know what is her arterial blood gas analysis.
Well, that's interesting. So she's recently has had a few episodes of hypoxia. At the time of the cath, her femoral artery saturation was 98%, and the mixed venous was 61. But she was recently admitted, and during that admission, she had periods where her arterial oxygen saturation got into the low 80s with minimal activity.
Yeah, but I think this may be due also to her low cardiac output. I believe that her cardiac output cardiac index was quite low during this
it was less than 2.
And as you said, it would be very difficult to treat her with any drugs which are currently used for pulmonary arterial hypertension because of the risk that she might develop more pulmonary congestion if you dilate her pulmonary arteries. I think that it is really very difficult to find something good for this patient except for trying to raise her even more, because anyway we all see that all filling pressures were quite elevated. And when I was looking at this case, I tried to write constriction in the question box, because in fact this tracing of the right ventricular pressure with square root sign was quite suggestive. And sometimes I believe that when you have post-radiation pericarditis, it may not be so thick. It's just fibrosis.
Yeah,
but this would only add another element, and I doubt that anyone would risk surgery on this patient.
No, she's So here, the RV end diastolic pressure, although you do have sort of that square root sign that you talked about, at end expiration, or RV end diastolic pressure is almost, it's close to 25. And then if you look here at our LV end diastolic pressure, it's 18 to 20.
Yeah.
So, and, I think those are all really good points. And then as you said, she could be in any number of things, and I didn't have any really good options. I did want to try some sort of, I actually tried a PDE5 inhibitor to see if she would be improved by that. But as Adam mentioned, that could be a cutting edge there, that you're not actually helping the patient. And so this is some data just looking at the different therapies for pulmonary hypertension and how much they actually help. And you see that none of them are really all that good, but the PDE5 inhibitors may have some benefit to exercise tolerance in major studies. So we tried it. We tried sildenafil. She didn't really tolerate that very well, and I think that two things happened. And number one, her respiratory status didn't really improve, and then the second is that I think she actually had some degree of liver failure as a result, because she started to develop asterixis, and her liver enzymes were okay, but she had pretty significant tremors. So I don't think that went very well.
Yeah.
So
maybe still resynchronization, the biventricular pacing would be something that could be considered, because it's clear that her contractions are not homogeneous. It's something that can be improved, maybe without great risk, if it is
yeah,
possible.
no, I think that's I would agree that's one possible thing, and we're not really having any good success with some different medical therapies. So I think that's an option. And I mean, she's pretty severely limited, so it's not like things are going okay. All right. Well, thank you all so much. This has been really fantastic. You guys had some great cases, great comments, and we appreciate everybody chiming in. It's really important.
Thank you for everybody attending. Dan, did you want to schedule a meeting for the writing committee while we have people online?
Yeah, well, that's set in stone, so to speak. It's every fourth Thursday.
That's great. So just want to reiterate that's what we're going to do then.
Yeah, same time. So that would be 2 weeks from today.
2 weeks from today.
And I need to get you some updated documents to post on the Gmail site.
Okay, that sounds great. Enjoy your vacation, and thank you everybody for coming. We had a great time, and thanks for your great questions. Bye-bye.
All right, thanks a lot, Eric.
Okay.
Thanks a lot. It was very nice, a very nice experience, and I'll be back for the next meetings. All the best from Poland.
All right, thank you.